You are live now, sir. Good evening, everyone. On behalf of Intas Pharmaceutical Limited, I, Dr. Mithilesh Nayak, welcome you all to this 10th edition in the webinar series Practice Pulse in Endocrinology. After the successful conduct of 9 webinar series on the different aspects in the field of endocrinology, today we are coming up with the yet another interesting topic in day-to-day practice of clinician, that is the polycystic ovarian disease. And to give us in-depth analysis and the management aspect of PCOD, we are having with us two eminent endocrinologists, Dr. Usha Sriram ma'am and Dr. Mala Dharmalingam ma'am. And to moderate today's session, we are having with us our course director for the webinar series, Dr. Subhankar Chaudhary sir. Dr. Chaudhary is a professor and head at Department of Endocrinology at SSKM Hospital, Kolkata. He is currently editor-in-chief for the Indian Journal of Endocrinology and Metabolism, and he is very active in the various medical associations, and he held the position of past president Endocrinology Society of India, past secretary for RSSDI. He is also a member for the subject expert committee CDSCO Government of India, and founder and patron for the South Asian Federation of Endocrine Society. So without much ado, I hand over the session to Dr. Chaudhary sir to take us further. Over to you, sir.
A very good evening and a warm welcome to all our friends across the country. I do remember we started this program, this monthly program, at the height of lockdown. Hope we don't have more lockdowns, severe lockdowns, but in terms of number of COVID patients now, we are far ahead of last year. But this program has run, and I think it's run partly because of the enthusiasm of the Intas team, but most importantly, because of the excellent speakers that we have had over the last 9 months. And this evening, we have decided to talk about polycystic ovarian disease, which is possibly the commonest endocrine abnormality that a woman in her reproductive life would entail. And we also have some topical interest added on because it's been found that women with PCOS or PCOD also have at least about a 30% higher chance of getting COVID, and again getting more complicated COVID. So that's a topical interest in this climate of more than 2 lakhs patients with COVID in our country daily. And the other issue is it manifests in different ways. We know it goes to different specialists, but I feel again, one may not sound smug, but as endocrinologists, I think we have a central role in leading the treatment of PCOS girls or young women. Of course, we need to take the help of others as well, but that we shall do as and when needed. So I will not go into all the manifestations or all the diagnostic issues or management that we shall hear from the experts, but you're all welcome to send in your questions so that we can try and answer. But remember, this evening we have something special, something that many of us may be passionate about, that is connecting art and science together. So we'll have a sand artist telling us the story of SGLT2 inhibitor. So hopefully you will all stay back even after this practice pulse in endocrinology. And I have the great pleasure of actually announcing the speakers, the faculty for this evening, and who are none other than Dr. Usha Sriram, who again might take us several minutes to go through our entire CV, but I'll keep that short because we want to hear her rather than to hear about her from me. And she is an excellent endocrinologist, and she has a tremendous commitment to women's health overall. Over the years, she has been passionate about this, and I'm sure she'll be happy to take this topic of polycystic ovarian disease this evening. And she's head department of diabetes and endocrinology at Voluntary Health Service in Chennai, and is a wonderful orator. Over to you, Usha, to take us through the diagnostic nuances in PCOS.
Thank you, Shubhankar, and what a pleasure it is to be part of this really, I think, interesting program today, and to share the podium or the virtual podium with my dear friend Mala. So, without again delaying things too much, I want to start sharing my slides, and then we can discuss the different aspects, as it has been said, the nuances of PCOS, especially the diagnostic aspects, because Mala is going to talk about management. I'm just looking for my presentation. Just 1 second. Here I am. So, how I plan to do this is actually take everybody through a set of clinical scenarios. So, PCOS is the most frequent reproductive endocrine disorder in women, as it has been mentioned already. I think the number is anywhere from 15 to 20%. And I have this picture because a clinical presentation of PCOS could be either one. It could be an obese woman, or it could be a normal weight, or even a thin person. And so, as we discuss the different scenarios, I will discuss also the nuances of that. So, the first real difficulty with PCOS is, as Shubhankar very nicely put it, people go to different specialists. They may go to dermatologists for hirsutism or acne. They may go to a gynecologist for menstrual irregularities, or for even infertility. They may go to a physician or an endocrinologist for diabetes or obesity. So, depending on whom they go to, then the way they are evaluated and diagnosed, I think, also changes. And the different professional societies, whether it's the Androgen Access Society or the NIH or ESHRE, they have some differences in the diagnostic criteria, but also some commonalities which we discussed. So I'm going to look at these 8 clinical scenarios quickly. First one is the classic, the phenotype, genotype classic. The second one is the obese phenotype. Third is the lean PCOS, then the adolescent PCOS, and the PCO morphology. And looks like PCOS, but is it PCOS condition? The pregnant PCOS and the menopausal, post-menopausal woman with PCOS is the question. So the classic phenotype, genotype is the first patient. A 26-year-old lady, she presents with excessive hair growth and irregular menstruation since menarche. Her BMI is 27. She's been gaining weight steadily since age 15. Her cycles are every 50 to 75 days with a few spontaneous, but mostly progesterone withdrawal induced. She has acanthosis, facial hair on the sternum, her arms and legs. She has acne, scars, and oily skin. So you can see the picture. It looks very much like what we would call somebody with a PCOS morphology. So the questions are, does she have PCOS? So that's a very important question to answer, because while I have described a very, very classic picture, it is up to us to find out, does she have PCOS and what workup should be done, and does she need an ultrasound of the ovaries. So these are the 3 major guidelines that we have in terms of this is the NIH, and then the Rotterdam criteria and the Androgen Access Society. So primarily most people use the Rotterdam and ESHRE guideline. So they say oligo or anovulation, clinical or biochemical signs of hyperandrogenism, and polycystic ovaries by ultrasound. And what they say is just you need 2 out of 3. If you go by this, she's got the irregular cycles, She's got the clinical signs of hyperandrogenism. So the answer is she has PCOS, and we don't need an ultrasound. That's how you can define based on this. If you look at the NIH consensus, you need to have both menstrual irregularity and hyperandrogenism. They don't talk about pelvic ultrasound, polycystic ovaries at all, but very important exclusion of other disorders like non-classical CAH, androgen secreting tumors, Cushing's, and the likes. The Androgen Access Society says you must have clinical or biochemical signs of hyperandrogenism. Of course, they would say that. Ovarian dysfunction, and then exclusion of other androgenesis or ovulatory disorders. So they say ovarian dysfunction or PCOS on ultrasound. So you can see that they lay the importance on the biochemical or clinical signs of hyperandrogenism. So you get the picture how each society is defining it, but most of us and the Endocrine Society goes with the Rotterdam criteria, which is 2 out of 3. So people present with varying degrees of, facial hair growth, body hair growth, acne, oily skin. So it's really important for us to do a thorough clinical assessment of the patient, look at their back, look at their lower portion of the back, look at their chest, and then this Perelman-Galloway score. Even if you don't actually do the number, you get a really good idea if you examine the patient carefully, throughout. So for making the diagnosis, one very important thing is to look at the metabolic picture of women with PCOS. So a fasting sugar, a post 75-gram glucose, not a postprandial, not a random glucose, not an A1C, but a 2-hour post 75-gram glucose, lipid profile, and transaminases, because steatohepatitis also can be present in women with PCOS. A pelvic ultrasound, and we're talking about this particular patient. I asked the question, does she need a pelvic ultrasound? If you're a purist, you actually have 2 out of 3, so you don't really need it. Then to find out what is the reason for her androgen excess, doing a testosterone, and for assessing her irregular cycles, you may need an FSH and thyroid function. Prolactin also increases androgens. So this is something very important. And then ruling out things like Cushing's and non-classical congenital adrenal hyperplasia. So this amount of workup will give us all the answers that we are looking for. So even the Endocrine Society, when it came with position statement in 2018, they said, we suggest testing for elevated androgen levels in all women with an abnormal hirsutism score. So we should check and make sure that we've got a decent score on the patient. But they said we suggest against testing for elevated androgen levels in women who are eumenoric, meaning their cycles are normal, with just some unwanted local hair growth in the absence of an abnormal hirsutism score. And the reason for this is 25% of normal women have polycystic ovaries on ultrasound. Absolutely normal women. And women, especially from Indian ethnic background and similar ethnicities, can actually have some degree of hirsutism without a significant Perelman-Galloway score. So it's really important to do a good clinical exam. So by ESHRE, you need 2 out of 3 criteria. And so this is how I would assess the classic phenotype, genotype person. Now, what about the person who's obese? So this 31-year-old lady, she complains of menstrual irregularities for the past 1 year. Her cycles are coming once in 40 to 60 days. Prior to this, her cycles were very regular. She has 2 children who were conceived relatively easily. Her BMI is 29 and she gained 15 kilos in the 6 months prior to all this happening. And that's because she fractured her knee and was completely immobilized. Her exam is otherwise unremarkable. So when she went for a checkup, they did an ultrasound. They found polycystic ovaries, and she has been diagnosed as PCOS, and she wants to discuss her treatment. So the first question is, does she have PCOS? Does she need a pelvic ultrasound? She already had it, and she has a polycystic ovary looking pelvic ultrasound. And what workup does she need? So the first answer, does she have PCOS? In my assessment. She does not have PCOS. Regular cycles from the start of her menstruation, had babies normally, everything is fine. She gained a lot of weight, and obesity itself leads to an ovulation. Obesity itself can also lead to some hyperthyroidism because the sex hormone binding globulin goes down in obesity, and that itself can lead to some hyperthyroidism. So we need to get back into the history of the patient, find out when did all this start. Is there something else that's going on, like the weight gain in this patient? So one has to be super careful about labeling someone as PCOS when everything has been completely normal up to the point when they started gaining weight. So all I would do in this patient is give her a lifestyle modification advice, get her to lose weight, and then see what happens to her menstrual cycles. Probably put her on hydroxyprogesterone acetate if every 2 months if she doesn't get her menstrual cycle. But what workup does she need? Definitely she needs, we want to make sure she doesn't have diabetes or pre-diabetes, and how her lipid profile is going, and how her liver enzymes are. So that metabolic workup I would do for anyone who is obese. So because you can see here, you take the obese PCOS woman, the obese normal person, and the non-obese PCOS, and look at their insulin sensitivity. The obese normal person also has, insulin resistance or poor insulin sensitivity. So we really absolutely must test them for glucose intolerance. Clinical scenario 3, a 21-year-old college student, irregular menstruation and severe acne, and she has hirsutism that is limited to her upper lip and lower abdomen. Her cycles only come once in 3 to 5 months and usually needs progesterone withdrawal. Her menarche was at age 11 and she got her next cycle after 1 year. She was born 2.3 kilos and her BMI now is 19. So the question comes up, can you have PCOS and be thin? So anywhere from 40 to 80% of women with PCOS can be overweight or obese, but there's also significant number of women who are normal weight or thin. So look at the presentations throughout lifespan. You can be born small for gestational age, you can have premature adrenarche, you can have adolescent PCOS, and during pregnancy you can have GBM or even present with infertility. You can develop type 2 diabetes, you can have cardiovascular disease, endometrial cancer. So the presentations vary throughout one's lifespan. I also want to say that when babies are born small, or this baby weighed only 2.3 kilos, you also have insulin resistance. So this may be one of the mechanisms why many of these women are having polycystic ovaries as they grow up. So how do we evaluate a thin, lean person? Absolutely the same way you would evaluate an overweight person and not think that they will not have these problems. How do they differ, these two people? Obviously the more obese they are, their insulin resistance is greater. And as I showed in the earlier slide, except that I would very, very seriously give them absolutely the same attention. Do women with PCOS have insulin resistance and diabetes? 100% absolutely yes, because insulin resistance is a big part of their pathophysiology. And do they need CV risk assessment? All women with PCOS need CV risk assessment. So this is just to stress the point that just because she's lean, it doesn't mean her risks are any less. Now, coming to clinical scenario 4, very, very important. 14-year-old girl is brought with irregular cycles, menorrhagia, acne, and weight gain. She has been reassured to have only pubertal hormonal imbalance because she does not have PCO on ultrasound. So her clinical exam is remarkable for acanthosis and acne, and her BMI is 27. So she is actually, brought in because she was having a lot of weight gain and some menorrhagia, and that's really the reason why she's come in, not because they think she has PCOS. But in reality, question is, do adolescents develop PCOS? We now know that PCOS is something that we are born with. It is a genetic disorder of insulin metabolism, insulin resistance. And so Definitely, adolescents can develop PCOS. But why does she not have polycystic ovaries? So to develop those athletic follicles that actually form the polycystic ovarian morphology, you need to have a few years of those anovulating cycles. And she has just gone through her post-menstruation, post-menarche a couple of years. So if we wait longer, she will develop a PCO morphology. So this is one situation, the only situation where you might want to repeat the ultrasound, and someone who didn't have polycystic ovaries will develop polycystic ovaries later. But once you have polycystic ovaries, it doesn't go away after that, so you don't have to keep monitoring it. So how do you differentiate these kind of girls from PCOS and normal hypothalamo-pituitary gonadal axis maturation, which can take anywhere from 2 to 5 years? We know that girls post-puberty can have irregular cycles for up to 1 to 2 years, some even up to 5 years. We know puberty itself can produce acne, and we know that there may be weight gain in part of whatever is going on now with adolescents. So we need to be looking for androgen excess because that's really not part, except acne, that's really not part of puberty. We should be looking for that. We should be looking for metabolic abnormalities like diabetes, pre-diabetes, looking for lipid abnormalities. So we need to do that workup in these girls because we can then manage their condition differently from reassuring that this is just due to puberty. So this is what an adolescent ovarian morphology can look like. That where the ovarian stroma still hasn't, the volume hasn't increased significantly. And as you can see from this, really what happens, why they develop the atretic follicles later is the functional ovarian hyperandrogenism, and then the local, the paracrine changes that are happening. All of that leads to the collection of atretic follicles, which then leads to the PCO morphology. So typically, demonstration of persistent hyperandrogenism in a patient with a persistent abnormal degree of menstrual irregularity fulfills the diagnostic criteria for PCOS, provided the endocrine tests are negative for disorders that mimic PCOS. We'll talk about that in a minute. So this minimalistic approach is 99% specific for PCOS in young women and meets international consensus criteria for diagnosis of PCOS in adolescents. So lack of hyperandrogenemia effectively rules out the diagnosis of PCOS in adolescents. But let's keep that in mind that it may not be clinical because some people familial genetically they are not hairy at all. They may have really smooth skin and we may never see hirsutism. But we have to look for other features and biochemical evidence of hyperandrogenism. So clinical scenario 5, this 27-year-old woman, she's been diagnosed with PCOS after she undergoes a master health checkup, found to have PCO on ultrasound. She has 1 or 2 irregular cycles a year, usually when she stops exercising, but otherwise she's fine. She has no features of androgen excess except for minimal upper lip hair. BMI is 23. She plays badminton regularly and has no health issues. So, does she have PCOS? Doesn't sound like she has PCOS. She has polycystic ovaries, and like I said, 25% of normal girls, normal women can have polycystic ovaries. So what does this polycystic ovarian morphology mean in clinical practice? So we need to, that's why, connect all the dots, the abnormal cycles, the clinical or biochemical evidence of androgen excess, the metabolic profile, and then the polycystic ovaries. So unless we carefully assess and connect the dots, we really cannot pay much attention to this polycystic ovaries on ultrasound. And then how should the ultrasound be reported? So typically they report it as so many follicles, the size of the follicle, the ovarian volume and all that. And there's a lot of discussion that we may have to see. Now we are saying more than 12 and 2 to 9 or 2 to 10 millimeter size, but they're saying we may have to increase the number of not just 12, but actually increase it to 20 or 25 even follicles to before you can call it as PCOS. But for now, at least one ovary is enough. 12 plus follicles 2 to 9 millimeter, and ovarian volume more than 10 mil. An ultrasound picture on one occasion suffices for diagnosis. Clinical scenario 6, 28-year-old woman, married for 4 months, presents with weight gain and menstrual irregularities. Noticed weight gain for the past 1 year with progressively increasing irregularities with menstrual cycles. She joined the gym, trying to eat healthy, no weight loss. So clinically, she has some acanthosis and increased body hair. So what workup does she need? How can we explain the polycystic morphology? And all these problems are all going on only in the last 1 year. And what did we tell? She just got married 4 months ago. So here is the most important part of PCOS diagnosis. Every society, they may have differences in other things, but they all agree on one thing. You have to rule out other causes. And then only it's a diagnosis of exclusion. PCOS is the diagnosis of, so these are the, I'm sorry, it doesn't show well, androgen secreting tumor, exogenous androgens, Cushing's, non-classical CH, acromegaly, genetic disorder, hair and syndrome, primary hyperthyroidism, amenorrhea, POF, thyroid disease, prolactin disorders. Now, this is the lady who came to see me, as you can see. And then we did her workup, history, physical, and did a overnight debt suppression, and then which was abnormal. Then we got a urine-free cortisol, and her hypercortisolism was confirmed. And then we got an MRI. It showed a tiny pituitary microadenoma. And then we did an inferior pituitary sinus sampling, we confirmed it. Then we sent her for a surgery. Following that, she became like this. So, this is the patient who became like this. And her husband was saying, I married this woman and then I got this woman. So, she just had Cushing syndrome, who presented like PCOS. So, the moral of the story is every patient with Cushing with PCOS, not the exceptionally classic one like it showed the first one, but it's such a simple test, the overnight dexamethasone suppression test. We must rule out Cushing's, we must rule out CH, non-classical, we must make sure that we are not missing, one of those things. Last two patients, 31-year-old lady, 8 weeks pregnant, undergone many years of treatment for PCOS, undergone assisted reproduction, presently on metformin 500 twice a day. So should pregnant women with PCOS need evaluation? Not for the PCOS, but they are at very high risk for GBM, pregnancy-induced hypertension, pregnancy losses. So we need to follow these women very closely, screen them for diabetes very early on. And obviously this being on metformin throws a spanner in the works, and so there are two ways of doing it. They can stop the metformin, reassess later, but while on metformin, you have to follow their fasting and postprandial and also pretend that they have GDM and give them a good diet advice. And when you can take them off, reassess them for any degree of gestational time. I'm not going to get into should they be on metformin and all that, which Mala will talk about later, or we can ask those questions. So they have significantly increased risk of pregnancy-related complications like GDM, hypertensive disorders, premature delivery, delivery by C-section, and the offspring may have increased risk of congenital abnormalities and hospitalization in childhood. So obviously needs very nuanced and careful attention. So screen for GDM early and increase the surveillance for pregnancy-related complications. Very importantly, monitor weight gain and follow postpartum for glucose intolerance, because GDM odds ratio is 2.94 and in some studies even higher, and a higher risk of conversion from impaired glucose tolerance to glucose to diabetes. The last one is we forget postmenopausal women. So this 57-year-old lady, 3 years postmenopausal, has obstructive sleep apnea and obesity. She presents also with postmenopausal bleeding, long history of menstrual irregularities during her reproductive years, and her pelvic ultrasound shows thickened endometrium and PCOS. So, does she have PCOS? Most likely. She has polycystic ovaries on ultrasound, and she has a long history of menstrual irregularities. How do we diagnose PCOS? I don't think we need to diagnose PCOS in postmenopausal women, but be aware that there is an increased risk of things like endometrial cancer in these women, and of course all the metabolic abnormalities. So this is the most important, that we need assessment for metabolic and other complications like cancer particularly. Which brings me to that they want to change the name of PCOS to metabolic reproductive syndrome. That because it really reflects the complex features of the condition and not just be harping on the polycystic ovaries that we see. And so this is really, really important. And very quickly, I just want to show you that people can have lipid abnormalities, they can have impaired glucose tolerance, type 2 diabetes, they can have, because of the obesity, multiple other hormonal imbalances, which can cause hirsutism just on the basis of both insulin resistance and the obesity itself. My work over the last few years has brought me to this frequent interaction with people with PCOS. They are at very high risk, 4 to 7-fold high risk of type 2 diabetes. So that is what I think we must be harping on with, to them from the beginning, that they are at very high risk for future type 2 diabetes. And unless we, bring it up, this is not going to be in their radar at all, and they are going to be only fixated on menstrual cycles or some hair here or there or things like that. So in summary, PCOS needs careful, unhurried clinical and biochemical and radiological assessment. It's often misdiagnosed and overdiagnosed, causing a lot of mental stress to young women, families, and to the healthcare system. And PCO is not PCOS. And what workup that we know, some things like should we do testosterone or free testosterone? How should we do those things? I can take it up in the question and answer session, partly because there is no absolutely one right way to do it. So we can discuss that. I thank you for this opportunity.
Thank you very much, Usha. That was a wonderful presentation. And I think if I have two takeaways from this presentation. One is that though the classic phenotype is obese, you can have non-obese individuals with PCOS. And second, stressing the fact that it is not just about ovaries, not just about cysts in ovaries. This is a systemic disorder. And so maybe we'll see a day when the terminology changes to metabolic reproductive syndrome. Now, we already have our chat box full with questions. We have to see how many of that we can accommodate, which of course suggests that the interest it creates amongst our audience. And I'm told that we already have about 700 people having joined in from different parts of the country. So we now, having heard about sort of the basis of PCOS, we now go on to management principles, and we have none other than Professor Mala Dharmalingam, who heads the Department of Endocrinology at MS Ramaya Medical College in Bangalore, and is also the director of Bangalore Endocrinology and Diabetes Research Center. And she has numerous publications to her credit, and she is an excellent speaker. And we shall hear Mala talking about the management principles. Of course, we cannot go through all the nitty-gritties, but we shall also only have the principles of management in PCOS. Over to you, Mala.
Thank you so much, Dr. Shobhankar. And let me just share my slides. Yes. So very good. Am I audible?
Absolutely. And your slide is visible.
Yeah, thank you. So very good evening to everyone, and it's my pleasure to be here. And today I will be talking about PCOS management, some of it, the principles, and also sharing with you some of the nitty-gritties of treatment. So basically, we have gone through this. Dr. Usha has given a wonderful lecture on PCOS. But just to say that there are now four distinct phenotypes that has been recognized. And the first one is what she has told is the classical one. And the second one is one which androgen excess with ovulatory dysfunction, which does not take the morphology. And then one you have with the morphology and the androgen excess. And the last one you have with amenorrhea or ovulatory dysfunction with polycystic ovarian morphology, where you may not have clinical signs and symptoms of hyperandrogenism. So basically, why are we worried and why do we have this meeting session on polycystic ovaries? This is our own study. The median age of the girls in our study was around 23, and we looked at the carotid intima media thickness. And what we found was right at that age of 23, compared to normal girls of the same age, the intima media thickness was much higher. It was significantly higher compared to the control group. And as we have seen that the cardiovascular risk is so high, and the carotid intima is a good reflector of the atherosclerotic process, we found that these young girls at 23 already had changes of cardiometabolic problems. So what are the treatment goals when we look at PCO? We need to reduce the hyperandrogenic characteristics. Of course, we need to manage metabolic dysfunction and decrease risk factors like obesity for cardiovascular disease and diabetes. We also need to look for contraception in women who are not trying to conceive. We need to prevent endometrial hyperplasia and cancer. And for those who are trying to conceive, we need to look a little bit into ovulation induction. And right at the beginning, let me tell you, in all of this, the patient preferences are very, very important. So we have looked at the polycystic ovaries, and much of it Dr. Usha has already discussed. But just to say, the insulin resistance is both central at the level of the muscle and the adipose tissue, as well as at the level of the pancreas, which has hyperinsulinemia, and that affects the ovaries, which cause ovulatory dysfunction, causing hyperandrogenism and follicular arrest. This hyperandrogenism causes increase of androgens and decrease of the sex hormone binding globulin or SHBG levels in the level of the liver. And the follicular arrest is the one which causes PCOM. And then this abnormality also occurs at the level of the hypothalamus, which causes the abnormal GnRH pulsation. You know, we all know that LH is more and FSH is less, and the ratio is abnormal. And this can continue the vicious cycle of insulin resistance and hyperandrogenism. So what do we do? The first, and I think if you take 1 to 10, I would say 1 to 7 is lifestyle modification. But believe me, it's not easy for them. It's not that they are obese out of choice. They are also trying. But we do know that androgen excess also causes increased appetite. And that is why it's very difficult for them to lose weight. So though the slide mentions obese women, it is for almost all women with PCO, lifestyle is a must. What do we include in lifestyle? Of course, weight loss. A little as 5 to 10% can reduce the cardiometabolic risk. How do we get there? Nutrition, caloric restriction is the goal that one should have. There's no one diet which is shown to be superior. There are so many fads, but you just need to have a caloric restriction. And exercise, as we all know, is a minimum 150 minutes. But you should also understand that these are young girls. So I just tell them, do whatever you like. You like to run, you like to play basketball, or you want to play tennis, do it. But anything aerobic and brisk and physical, so that there is expenditure of energy. Then how do we monitor that? We have to have goal setting and self-monitoring. They are also worried about it. That is why they have come to you. Very young girls are brought by their mothers, and mothers can nag, and that sort of makes them not want to do anything. So a little bit of counseling, but of course I give an accountability to them and said, okay, between us, how much weight do you think you can lose? I allow them to choose the kgs. I say, this is what I expect, but what do you want to do? And then we keep them accountable, and of course a little bit of cognitive therapy of what they are going through. Weight loss drugs, most of them are out of market now. But so if you feel that you're on a high fatty diet, maybe one of them you can give. We know we have only Orlistat now, but so I always encourage them to do it themselves. And many of the girls also say, no, doc, we don't want to take any medications for weight loss. But however, a study in 2017 looking at a large number of these women showed that bariatric surgery actually reduced obesity and insulin resistance, as we know, which decreased their androgen, hirsutism as also, and return of ovulatory cycles. But this is only in the severe obesity person we recommend this. Goals should be very smart, specific, measurable, achievable, realistic, and timely. And I cannot say enough about psychological counseling. They come with so much of body image concerns, disordered eating. We need to look at it. And medicines are not the whole treatment. So a whole holistic approach is very much required, not only pharmacology, education, lifestyle, and counseling. So now what do we give? Many of the patients do come to us with irregular cycles. So the combined hormonal contraception is thought to be, by most societies, the first line of therapy, in combination, of course, with lifestyle. And what do? They suppress the pituitary LH. This is the mechanism. They suppress the ovarian androgen production, and they increase the SHBG, so binding the testosterone. And this corrects the irregular menstrual cycles. Also in sexually active women, gives contraception, provides endometrial protection. As you have seen, Dr. Usha showed that the endometrial thickness increases because of estrogen action and progesterone is not acting. And that is in endometrial hyperplasia, which later can go on to even cause cancer. So something we should prevent. And it also reduces hirsutism, acne, and other hyperandrogenic features. So which hormone contraception? Nothing is superior, no one formulation. Consider lowest effective dose. And we always avoid the most androgenic progesterone like levonorgestrel. This is only given in girls with menorrhagia. This is the second line. Most of the drugs may have levonorgestrel, but this is a second line, second generation group of combined oral contraceptive and given only for menorrhagia. But otherwise, nowadays we are saying to give norgestimate, which is very low androgenic and with less side effects. Of course, if the patient does not want to take an OC pill, you don't need to tell them to take. You can give them other options. But if you're giving them just a withdrawal, then it is just a withdrawal. It will not do anything to improve their metabolism or acne or hirsutism and so on and so forth. So this is a little bit of not a very clear slide, but just to show you that there are first generation, second generation, third generation, and fourth generation progesterones. And the third and the fourth generation is what we prefer. So what is the recommendation of this 2020 guidelines? They say it's highly effective in treating irregular cycles and menorrhagia, and it's the first and second generations are preferred in acute menorrhagia, the third and fourth generation for actually treating for polycystic ovaries. And so basically these are the guidelines. So how do they work? The estrogen component of the combined oral contraceptive pill suppresses FSH, which is important for us, and stabilizes the endometrium. It increases the SHBG, like I told, and that thereby decreases the free androgen or the free androgen index. What does the progesterone do? It decreases the frequency of the GnRH pulses. We know that LH increases, so that is sort of decreased. The surge of LH is inhibited, and all the rest is due for contraception. And possibly it has some androgen blocking effects, and again increases SHBG concentration. So both estrogen and progesterone increase the SHBG concentration, decreasing free androgens. So the other pathophysiology is hyperinsulinism. So the hyperinsulinism exists both at the periphery, which is what we see in gestational diabetes, in diabetes itself, type 2 diabetes, which is peripheral insulin resistance at the level of the muscle and the fat, which I've discussed earlier. But insulin resistance is also present at the level of the ovarian theca, which has excessive androgen production. So because of the IGF-1 receptor. So again, this vicious cycle is formed where you have increased androgen at the liver, and this decreases SHBG and increased free androgen, increases glucose, and again increases insulin at the level of the pancreas. So this again forms a vicious cycle. It's very important for us to reduce the hyperinsulinism. How do we do that? With people with features of hyperinsulinism, metformin is the drug of choice. You can consider it PCO who have a BMI of more than 25, along with combined oral contraceptive pills and lifestyle. And if they have metabolic features, then definitely yes. And sometimes, though the risk is very low of putting on weight, and with a very low doses of estradiol, the metformin may have some beneficial effects when it is combined. So can restore ovulatory cycles, may be associated with weight loss, and this is the dose of 1500 to 2000 milligrams per day in divided dosing that we give to our patients. So this I won't go through because Dr. Usha has nicely shown this, and this is our patient. And the other problem they come to us is for hirsutism. Irregular cycles we have looked at. Hirsutism is the next most important problem. And the first line of treatment, even for this, is the combined oral contraceptive pill for the reasons that we have mentioned. Second line is to give the combined oral contraceptive pill with spironolactone. So, however, if the patient does not want to take a combined oral contraceptive pill, they can take spironolactone alone. And if this doesn't work after 6 months, then you can add another anti-androgen, which we'll discuss later. Along with this, we do recommend that they should remove their hair in a mechanical way. And anti-androgens we have discussed, so I won't go through this. And acne is what I was showing in the previous slide. Yes, they can be used for that also. So these anti-androgens that are there are spironolactone, and which is an androgen receptor antagonist, and also an aldosterone antagonist given in the dose of 50 to 100 twice a day. Finasteride is 5-alpha reductase inhibitor, which is given at 5 milligrams per day and better tolerated than any other anti-androgen. Flutamide we rarely use now. It's another androgen receptor antagonist, which had a rare thing of hepatitis. So now we don't use. We are very happy with spironolactone and, if required, finasteride. So topical treatment with eflornithine is very, very controversial. There are some guidelines which say it's good, and the other guidelines say it does not work and it's ineffective. But however, it's an inhibitor of ornithine decarboxylase, and many studies have shown that roughly 60% of women may benefit with this topical treatment. The last part of it is infertility. We are looking at ovulation induction. Of course, before we go in for the ovulation induction, we have to rule out male factors, tubal problems. And till now, we always thought that clomiphene citrate is the first line of ovulation induction in women. However, in 2018 and 2 Cochrane systematic reviews have said that letrozole is superior ovulation rates. And of course, now letrozole was in the middle band in India, but now it's again available and can be used and is found to be little superior to clomiphene citrate in conception. So letrozole mechanism of action is inhibits aromatase in the ovaries. You know, aromatase converts estrogen to testosterone in the aromatase in the ovaries and peripheral tissue, and decreases estrogen feedback on the hypothalamus, increases the GnRH release, increases FSH from the anterior pituitary, and estrogen rises from the follicular growth, and estrogen suppresses FSH, meaning the negative feedback is inhibited. So this is how it works. It decreases aromatase at the periphery, and at the level of the hypothalamus, it increases the gonadotrophins, and the estrogen prevents a negative feedback. The increase of estradiol prevents, so the gonadotrophins is normalized. So that's how and that has an advantage at the unstimulated ovary. But of course, there are some hyperstimulation effects, which we can discuss in the question answer. The other drug is clomiphene citrate. The mechanism of action is it binds estrogen receptors in the hypothalamus, decreases again the same, sort of the same mechanism, where it decreases the negative feedback of estrogen and increases GnRH, stimulates the follicular growth. It also has anti-estrogen effect on the endometrial lining and the cervical mucus. And however, at high and repetitive doses, the effects of this is much more. So this is basically the mechanism of clomiphene citrate. So what is the role of gonadotropins in infertility in PCOS? Yes, injectable FSH can be given who have failed the oral agents, and it's a second line. So we usually start at a very, very low dose. There's an increased risk of multifollicular development, multiple gestation, and over hyperstimulation. So these are the side effects of gonadotropins, in fact, of any of the infertility treatments. So basically, in a nutshell, if I have to put what is the treatment of PCO, less than 30, more than 30, you can say BMI, and then you can, if for infertility, this is letrozole or clomiphene citrate. If not working, you can go for gonadotropins. There are IVF centers who do practice laparoscopic ovarian drilling, failing which they would have to go to IVF. And if the BMI is more, weight loss is very, very important. And of course, then you consider for ovulation induction. And if they are not able to lose weight and the gynecologist says, no, you have to, maybe in them who are very severely obese, you can consider bariatric surgery. So to conclude, PCO is an opportunity of prevention, just like how Dr. Usha was telling, that the main problem, especially in adolescents, in the young 20 women, is to prevent diabetes and other metabolic conditions. I think this is an opportunity all of us physicians should grab with both our hands and counsel them so that we can prevent in already a country which has got such a burden of diabetes. We cannot have the younger generation who are getting more and more PCO to become diabetic. And it is a treatable, controllable condition for all the symptomatology they may have. It has a multifactorial approach, and everything depends on patient's choice. And out of which I would say, if there's a take-home message, the lifestyle modification is a very, very important aspect of treatment. So is counseling. So thank you very much for a patient hearing. And of course, if there are any questions, I would like to take them in the question answer session. Thank you.
Thank you very much, Dr. Maladhar Lingam. It was wonderfully compressed within this time span of probably 20 minutes, which is difficult to talk on all the various aspects of treatment of polycystic ovarian disease. But of course, you have captured the essence that it has to be, first of all, lifestyle management and prevention of the metabolic complications, and then further treatment according to the individual need, whether it's for hirsutism, whether it's for infertility, whether it's for irregular periods. So now I'm now told that there are more than 1,000 attendees right now in this exciting session this evening. We've got several questions as well. Let's try and get our experts to answer at least some of them. So if we start with a very basic question from Dr. P.K. Shah. Now, how to define irregular menstruation in adolescent girls? Maybe Dr. Usha Sriram, you take that up. You mentioned that.
Yeah. So, like I said, typically when we say someone has oligomenorrhea, we are talking about less than 9 cycles per year. And then at a given time, they have not missed more than 2 cycles. So, if you talk about adolescents, right after menarche, as much as 80% of the girls, by the end of 1 year, their cycles would have regularized, meaning they'll be having monthly cycles. And then in another 10% or so, by the end of 2 years, they're having regular cycles. So it's actually a small number that will go on beyond 2 years after menarche to continue to have any degree of oligomenorrhea. So I just think it's really important to take that history. When was your menarche? How was it right after that? How many cycles did they have per year? And then, when did it start getting irregular like this? And very classically, you'll get a history that around between 10th standard and 12th standard, when girls are, sitting down and reading a lot and not having any physical activity, and weight gain happens, whatever is going on gets further amplified, and all the problems get worse.
Right. Yeah.
And I would add to that. just to
Yes, and Mala, can I request you to stop sharing your slide?
No, I to do something. Ah, yes.
Yeah, yeah.
Sorry, I thought they will do it from the thing. Yeah,
No,
just
no,
to
no.
make it clear for the audience, I think Dr. Usha has put it very brilliantly, but basically it is the guidelines say between after 1 year of menarche to 3 years of menarche, a normal cycle is between 21 to 45 days. After 3 years of menarche, it is 40 days and less than 8 cycles a year.
Yeah, and I just wish to add that when we are eliciting the menstrual history in the context of polycystic ovarian disease, I think it's not just less bleeding. You can have less bleeding and infrequent bleeding, but you can also intermittently have heavy bleeding, right? So now we have, let's say, uh, maybe to Mala, Dr. Suresh Chand Jain. Again, it's why PCOD is so common nowadays in young girls.
So basically, I think it's basically a genetic problem, and we have huge diabetes in our country. And super added to that is the increasing obesity that we are seeing, which is increasing the insulin resistance, whether it is only the environmental factors or the epigenetics, all of them combined together. I think that is why we are seeing more and more polycystic ovaries. In like when I started maybe 25, 30 years back, to see a woman or a girl of 23 around 100 kilos was almost unheard of. And now in my OPD, at least 2, 3 girls come with 100 kilos. And of course, obesity adds to the insulin resistance. So maybe that is one of the reasons why the PCO is so common nowadays.
That possibly, yeah, most important reason. And while you are on it, what's the treatment for acne in a PCOS patient?
Yes, that is.
Acne, however, can be otherwise. Maybe they even without features of hyperandrogenism.
For acne alone, without, again, this combined oral contraceptive pills, which are anti-androgenic, can be used and they may be beneficial with drosperinone. The other is, of course, a very small dose of finasteride. 1 mg of finasteride can be used, and even spironolactone at a small dose of 50 milligrams will help in reducing acne.
Yeah, for acne in the absence of hyperandrogenism, maybe we also could take the help of the dermatologists where isotretinoin or tretinoins may also be used, right? And back to Usha, how to diagnose PCOD in primary care. So the question is from Dr. Mushaq Ahmed. He asks clinically, but whatever, overall, how should we diagnose in a primary care center?
So usually women are coming in with either menstrual irregularities, or they're coming in with, as Anna just mentioned, about acne or scalp hair loss in women, male pattern hair loss, or they're coming in with just for assessment of obesity, and then when you take a history, you find out all this. In terms of further workup, I want to stress here there are a lot of things we don't need to do. For example, we must do a fasting sugar and a post 75-gram glucose for assessing glucose intolerance, and not insulin levels or HOMA IR or any of those things. Post glucose insulin levels and all that. Those are all terribly expensive and completely not necessary. So we don't need to do all that. We must stick only to the glucose test, and then do a lipid profile, very important. And then for assessing the androgen clinical features of androgen excess, we can do a total testosterone. If your lab is doing a very good pre-testosterone with equilibrium dialysis and the good technique, then you can order free. Otherwise, a total is just fine. And then only in people with very severe clinical evidence of androgen excess, we need to be doing things like DHA sulfate or added tests. So that, and only when clinical evidence points to a possible androgen producing tumor. Otherwise, we just need to remain in that lane of assessing for metabolic abnormalities, getting a testosterone, so that we are not missing anybody who might have a androgen producing tumor or something like that. Definitely, if they have only one, for example, they just come with irregular periods and no androgen exists, then definitely get an ultrasound.
Right. And I'll ask you first, and then Mala as well. So, how often in your clinical practice, in someone whom you suspect to have polycystic ovarian disease, do you go through the checklist of exclusion of NCCH, uh, hypothyroidism, acromegaly, Cushing's, and what about prolactin? Do you ask all of these in your patients?
So if they have significant secondary amenorrhea, if they have secondary amenorrhea, I always ask for FSH, prolactin, and then but in people who come in with
First of all, of course, exclude pregnancy. Whoever comes with secondary amenorrhea, yeah,
they're sexually active, or we must exclude pregnancy. Being a endocrinologist, I think I'm partial to looking for non-classical CH and ruling out Cushing's in such a simple thing to quickly rule out, so you don't miss out such ominous things. And I probably want to say that I do this in about 50 to 60% of patients in my practice.
right. And Mala,
So my general workup in a typical, who clinically I strongly suspect PCO, is a testosterone and a prolactin, and who is having cycles once
and
in
Hannah, how do you interpret the prolactin? The prolactin is 30, 35. So is it because of PCO?
That will be typically my PCO level of prolactin.
Right. Okay.
35, 40.
Beyond 35? Beyond 35, is it hyperprolactinemia?
Up to 40, 45, 50, I
Okay.
see in prolactin in
Right. Yeah.
POT. More than
Sure.
that, I will see other causes or something. And these are the two things I usually check. But if it's a lean PCO, I would definitely do a 17-OHP. And if I have some suspicion of
Right.
things, I will go ahead and do an ONDST.
Sure.
In our case, we do a DHEAS because incidentally, Dr. Suryanarayan had picked up a typical PCO and he did a DHEAS was very, very high, and then that person turned out to have an adult tumor. So,
Right.
do that as a routine.
Right. So I know we are overstepping our time limit, but we go through at least a couple of more therapy-related questions. One is Dr. Pankaj Patwari. Obese PCOS with Hirschsprung, what is your OCP of choice? With dyslipidemia, what changes to make in ethinyl estradiol dose and which progestin to choose? So you have already, Mala, you've already referred to your OCP, but actually, can you tell me which OCP has not estimate in our country?
Which one?
We said,
Oh, not just
you said not estimate.
mini,
Which is the one?
You can have mini. There's one tablet called mini. And you
Mini,
have
okay.
many of them. Actually, the Glenmark one just says not estimate with ethinyl estradiol. Ethinyl estradiol is 0.03 mg. And
Right.
so there are many companies which are having that. So
Eventually, So this is the specific question. So obese PCOS with Hirschsprung, which is the OCP of choice? And if it's with dyslipidemia, do you make any adjustments to your ethinyl estradiol dose?
No, we are itself giving a very, very small dose of ethinyl estradiol, 0.03 mg. So it is very small. We don't expect much of lipid abnormalities with that. But of course, we do counsel them on lifestyle. And if the patient is told this and they say, I don't want to take a combined OCP, we don't insist. We say, okay.
Right.
And sometimes if they have some headaches or something like that, we may just give a progesterone also.
Right. And can we go back to Usha? Dr. Vinay Bajaj, do SGLT2 inhibitors have any role in the management of PCOS? They are into everything nowadays, so do they also protect the ovaries?
Sorry, can you repeat? I didn't get that one.
It's the role of SGLT2 inhibitors, potential role in PCOS.
Not that I know of.
Right, yeah, because maybe we will be telling the story of SGLT2 inhibitors through art. Maybe people think that SGLT2 inhibitors must be important. In future, of course, it may have, but at this point of time, they have not been shown to be of use. But of course, potentially they could be of use. Yes,
Just
Mala,
a
you
small
were
thing.
going to.
GLP-1 analogs have been, there's a very good article in Nature about GLP-1 analogs and the GIP and GIP together having very good role in PCO. That is
Yeah.
the tide.
Yeah, partly through weight loss. Yeah. And then Dr. Kumar asks, what is the risk of cancer in patients with PCOS? And this will be the last question before we go on to the art part of this evening's program.
So it's high, both breast cancer and uterine cancer. So, because PCOS is at that intersection of obesity, which increases risk of cancer, type 2 diabetes increases risk of cancer, hyperinsulinemia, risk of cancer. So, so all the factors are there. And we well established. There's good epidemiologic evidence to show increased risk of breast CA and endometrial CA. So that should come as part of our overall screening of these women as they get older.
Right. Yeah. So I think there would be many more questions which are still in your minds, or even if they're expressed, possibly we can't take any more questions this evening. But I must thank both the speakers for the wonderful coverage of this common area of polycystic ovarian disease, and the fact that it should nowadays be looked at not just an ovarian problem, but overall a systemic issue, including important portenders of cardiovascular risk, possibly. Though, of course, I must admit, though, we all talk about the higher risk factors that are present in women with PCOS for development of cardiovascular events. But if you try and look for evidence, prospective studies, which have showed that higher other fatal or non-fatal cardiovascular events, those type of studies we haven't yet got. But it is so important that we build on take this opportunity, as Mala has already mentioned, grab with both hands this opportunity to improve the metabolic health of our young women, so that we provide them much healthier lifestyle, overall healthier life in future. So with these few words, profuse thanks once again to Dr. Usha Shriyam, to Dr. Mala Tharmalingam, and to all of you as part of the audience. Now it's 1200 plus audience who have participated in this program, but all of you please stay back. Hope you don't leave us immediately, because we have something exciting, something novel coming up. So we will have a sand artist. How many of you have seen a sand artist? And so we have none other than Mr. Nitish Bharti, who has a lot of acclaim. He has been on the India's Got Talent. He's been finalist there, semi-finalist of Asia's Got Talent. Has been shortlisted in Cannes short film nomination. And so let us see the story of SGLT2 inhibitors from the lens of a sand artist. So over to you, Mr. Nitish Bharti. I hope Mr. Bharti is ready.
You are muted, Mr. Bharti.
Okay, it's cool.
Great.
Yeah.
Wonderful to see you.
Thank you so much, sir. It's been completely my own pleasure, and so we have a really good relation with the INTAS. This is not for the first time we are working. We have a quite a history from 2012 and then coming to 2021. It's been always pleasure to perform for this brand. This brand is have some emotional kind of touch to me, and the kind of story we are presenting today, it's all about the SGLT2. So being an artist, this is the great thing, I guess, happened to me, is that I can get to educate in so different segments. And when you talk about diabetes, or when you talk about a disease like a diabetes, which is like we have over 77 million people affected by this in the country, and then some invention comes like SGLT2, and that helping diabetic people, not just controlling the sugar level or the glucose, but also helping them in the parts like heart, liver. So telling this story, I'm myself educating, into these things, what is happening around the world and how the things are changing and how the scientists and, the researchers are taking efforts to make our life better, to make all the patients' life better and happier. So I have made something, my whole team and, for the whole team of Intas have put it together, and here we are presenting something very special to all of you.
Diabetes is a leading cause of cardiovascular and renal disease. CVD is leading cause of death in this population. Conventional diabetes drugs like insulin, metformin, sulfonylureas, glitazones, etc. have limited effectiveness to improve cardiovascular outcome. Development of the SGLT2 inhibitors marked the beginning of an incredibly exciting period for management of diabetes beyond glucose control. Here is the incredible story of harnessing the kidneys to help treat diabetes. It started with identification of SGLTs, novel proteins that transport glucose in the kidney and intestine. SGLT2 protein are responsible for 90% of the total glucose reabsorption as urine is made. SGLT2 inhibitors thus inhibit renal glucose reabsorption, which leads to enhanced urinary glucose excretion and lower glucose in blood. Discovery of SGLT2 inhibitors started 150 years ago with the identification of fluorescein in apple tree root bark, which could inhibit SGLT1 and SGLT2 proteins, but its therapeutic use was hampered due to short half-life and intestinal side effects. new era in management of diabetes started with the introduction of first SGLT2 inhibitor, canagliflozin, followed by dapagliflozin, empagliflozin and remogliflozin. Cardiovascular outcome trials done with most classes of diabetes drugs have confirmed cardiovascular safety, but after SGLT2 inhibitors, the focus has shifted from glucose lowering alone to CVD risk reduction. Initially, SGLT2 inhibitors were also primarily indicated as glucose-lowering agents, but due to pleiotropic effects, the focus is now on cardiac and renal outcomes, heart failure and mortality rates reduction. SGLT2 inhibitors are now recommended treatment strategy in individuals with and without diabetes, including heart failure and kidney disease. India has an estimated 77 million people with diabetes, which makes it the second most affected in the world. Indian phenotype type 2 diabetes mellitus have multiple risk factors and are at higher risk of cardiorenal complications. Transform their harsh realities into healthy possibilities. Welcome to the new era of diabetes treatment, which offers wellness beyond diabetes control. For powerful glycemic control with established benefits of cardioprotection and renal protection. Presenting Dapavel. Every sales pack of Dapavel comes in unique mono carton with patient advice. Dapavel is most affordable dapagliflozin. When a patient is diabetic, hypertensive and obese and his HbA1c is not on goal, he needs more. When a patient has diabetic dyslipidemia, is smoker and his HbA1c is not on goal, he needs more. When a patient got heart attack and his HbA1c is not on goal, he needs more. Intas leaders in cardiodiabetotherapy introduces in type 2 diabetes mellitus with multiple risk factors prescribe Dapavel M, dapagliflozin 5 to 10 mg with extended release metformin 500 to 1000 mg tablets. Wellness beyond diabetes control. Dapavel M is available in complete and comprehensive range and is most affordable dapagliflozin with metformin XR combination.
Sir, you are live.
So yes, this was the whole story of SGLT2. Hope you all guys have liked it, and if you have any questions, we can go ahead.
I think it was fascinating, wonderful, and a big God bless to Nitesh and his team. Wonderful.
Thank you so much, sir. Thank you.
Maybe the final comments from Intas.
Yes, sir. Thank you very much. And I think it's been a great opportunity for all of us to be witnessing this unique event. But I must thank our speakers for tonight, Dr. Mala Dharmalingam and Dr. Usha Sriram, for accepting our invitation for today's program, the 10th edition of Practice Pulse in Endocrinology, and we had a very important topic of PCOD to be discussed. And we thought that this is a great opportunity for us to showcase our Dapawell, which we introduced post patent expiry, and now we are introducing Dapawell M, again the most affordable brand of dapagliflozin and metformin combination. And I am really grateful to you, sir, Dr. Shubhankar sir, for continuously guiding us and helping us to do these programs. And as you rightly said in the beginning of the program, that the most important reason why this program is running is the speakers that we have, and you have always been a guiding force in helping us choose the speakers and the topics. And we hope that this program will continue to run in times to come, and we shall witness many more such programs which are useful for practicing physicians across the country, because endocrinology is a subject which most of the physicians would like to learn, and I'm sure they are getting the benefit of this. So thank you very much once again from all of us at INTAS, and we look forward to seeing you again maybe next month, and we will have a very exciting topic next month as well. And thank you very much once again. We had more than 1,500 doctors who witnessed this program today, and we are really grateful to you, all of you. So thank you very much, and thank you, Mr. Nitish Bharti, for coming here. I remember you came for our T-Glip M launch in Goa, and that was a big brand for us, and now I'm sure Dapawell M will also become a very big brand.
Definitely.
So thank you, Shubhankar sir, and thank you very much, sir, and thank you, Dr. Usha, and thank you, Dr. Mala. Thank you once again, and good night to all.
A very good night.